Okay, so we are recording officially as of now, and I'll try to post that later today. So just a couple quick announcements. As you know, tomorrow we have a quiz. It'll be the same deal. It'll open at 12 noon and close at 11:59 p.m.
U.S. coronavirus death toll now rising above 100,000. This now, Tracy.
I'm just muting microphone so it's quiet for everybody here. Okay, so just a quick reminder, quiz tomorrow. That will be over what I'm going to do a quick review for today. Tomorrow I will have a meeting at 9 a.m. It's going to start the section on the muscular system. That will not be on your quiz. So at the end of the talk today, I'll take any questions that you have. But for now, I'm just going to get running on a quick review of bone fracture and repair, which I've already done, and a few of the bone diseases, which we've talked a little bit about osteoporosis, but I'll get a little bit more specific with that. So during bone fracture and repair, I'm going to just breeze through this because I have talked mostly, we've done the steps of it. I just want you to remember for tomorrow's quiz, I am going to expect you to know the different types of fracture. And what I wrote out, I believe in our previous lecture, is classification. So I'll write that in parentheses. By this classification, I mean the three classifications of position, complete or incomplete, and closed or open. That's classification. I'm also going to expect you to know the description, the common types of fractures, which is table 6.2 in your textbook. So I'm going to put, this is common, sorry about the writing, common types, okay? So to run through those really quickly, they're just comminuted, it's hard to say, compression, spiral, epiphyseal, depressed, and what's called green stick. Comminuted is just when we break a bone and it gets fragmented into pieces. Compression, just like it sounds, is when a bone gets crushed somehow, and that causes a fracture. Fracture just means break if you're not used to that terminology. I know most of you know that. Common bones that get compressed are porous types of bones, which also get osteoporosis, by the way. There's something called a spiral break. So if that's from torsion or twisting of a bone, that causes a spiral break, and that usually happens in athletes, people doing sports who twist on, usually in their lower extremities. An epiphyseal fracture type is when the actual growth plate separates. Young people who still have active growth plates where they're not finished growing, and those epiphyseal plates are still cartilaginous, they're still hyaline cartilage. Oftentimes what happens is the tendons around that area, the tendons and ligaments around that area tend to be stronger than the connection of the epiphyseal plate itself. And so there can be a displacement of that growth plate. Depression, that is just when it's a typical skull fracture. It's almost like a puncture, but it's when the bone gets pushed inward on a cranial plate. That's common. And green stick, that funny name, is when a bone breaks incompletely. It doesn't go all the way through the bone. So green stick would be something like this. I had a green stick fracture when I was young in one of my fingers. And it's just when the bone breaks partially through the bone, like I'm drawing, but not all the way through. So I do want you to know what those common types of fractures are. Now, when we go over stages of bone repair, I already did this, but I'll review it very quickly. There's 4 major stages. So I'm going to verbally go through those. Number 1, hematoma form. Hematoma, that word just means blood clot. So actually any bruise, when you get a bruise on your skin from trauma or bumping something, that's just a blood clot forming under the skin. That's also a hematoma. So anytime a blood clot forms, we call that a hematoma. Well, when a bone breaks, we get a blood clot forming in that area. So we get a massive blood clot forming at the fracture site. The cells in that, living cells in that area die, bone cells and some blood cells, tissue cells, and we get inflammation. The tissue swells in that area. Inflammation, by the way, just means a collection of fluid. That's what causes inflammation, or that's what it is. The second step is a fibrocartilage callus forms. So fibrocartilage forms prior to any new bone forming. So if I have, I'm going to draw a bone break here really quickly. Stage 1, a blood clot forms in that area. So we get a mass of blood clot forming here. Living cells die, and we get inflammation in that area. That's a mass influx of fluid, usually caused by vasodilation and diffusion of that fluid out of the bloodstream. Number 2, a fibrocartilage callus forms. I know I drew something like this before, but so we get new blood vessels moving into this area. This is phase 2 or stage 2. So blood vessels move in to bring nutrition, and phagocytic cells clean up the area. So immune cells, I'm just going to use green, they clean up the debris, all the dead stuff. So phagocytic cells gobble up the debris, the dead stuff. Fibroblasts, chondroblasts, and osteogenic cells invade. That's from this, they come from these blood vessels coming into the area. So blood vessels invade this area, and they bring not only nutrition, but they bring fibroblasts, chondroblasts, and osteogenic cells. Then they get to work on the repair. Fibroblasts, you know, that's an immature fiber cell that secretes fibers. They start secreting fibers and form a fibrocartilaginous callus. So a fibrocartilage callus just means this sort of cast-like thing that forms from the fibroblasts secreting fibers, and we get fibrocartilage in this area. Start to mending. So really repair doesn't happen until stage 2. Stage 1 is just a setup. Then stage 3, the fibrocartilage actually gets converted to spongy bone, and it's called the bony callus forms. So during stage 3, fibrocartilage becomes trabeculi of spongy bone, and I'm just going to use black. This fibrocartilage callus turns into actually a bony callus from the conversion of fibrocartilage to actual spongy bone. It looks like I've drawn compact bone here just because but technically in stage 3, trabeculi form, those little bone spicules, little bone needles. So that's stage 3. We start to get endochondral ossification. That just means bone forms from cartilage tissue. Stage 4, then this spongy bone gets converted to compact bone over a long period of time. So we're talking several months. Osteoblast and osteoclast activity then remodel this spongy bone into compact bone. And that can last up to 12 months, stage 4. And just as a final note, this bone repair that occurred, this new bone, that is now complete. I'm just going to draw in compact bone. I've exaggerated this callus size. When we break a bone, it's not nearly this dramatic. You might see on a new bone a little bump like this, where a bony callus forms. So I've just exaggerated it in my picture. This new bone, just remember, is typically much stronger than old bones. So should we receive trauma to this area in the future, usually old bone will break in the area prior to this new bone because it's stronger. So we rarely break a bone in the same place twice. Now I'm going to talk a little bit more in depth about bone disease. So let's just layer on a page. So I just wrote bone diseases, osteomalacia and rickets. Osteomalacia just means basically soft bones. I'm just going to list what you need to study for the quiz on bone diseases. Osteomalacia, or soft bones. This, and by the way, rickets, I'm going to write under here, is just a form of it's a type of osteomalacia in young people. Okay? Children, mostly. And osteomalacia, or soft bones, is a result of lack of mineralization of bones. So what makes our bones quote unquote soft? We call them soft in this disease. I'm just going to put lack of proper mineralization. So osteoblasts are still doing their business. So true or false, osteomalacia causes a decrease in osteoblast activity. That's false. So osteoblasts are still laying down osteoid. There's our happy osteoblast. It's secreting osteoid. But remember, in order to have proper ossification or proper bone production, we need minerals to mix with the osteoid. So our osteoblast, I'm going to label this, is still doing its business. It's that the blood vessels coming into this area are lacking proper minerals. That means we didn't get enough of those minerals in our diet or from, say, the sun. So minerals are not adequately deposited in this area, so this stuff never mixes and gets hard. That's what osteomalacia really means, or soft. That's why it's called soft bones. So the causes are lack of calcium in the diet and or lack of vitamin D. This is a bit of a two-step process, and I'm going to explain it to you. We need to ingest calcium. Our bodies don't make it. And now you know we need a whole lot of calcium because there's so many functions that our body uses calcium for. That's why we store so much of it in our bones in case we can't get enough of it to eat. So nevertheless, we can ingest calcium So we need to eat calcium. If we don't eat enough calcium, ingest enough calcium, that may cause improper mineralization and soft bones. So that's one way we can get osteomalacia. Also, we can eat calcium all day long, but if we don't absorb that calcium in our intestines into our bloodstream, and we just get rid of it in our urine, that also is not getting calcium into our body. And what assists the absorption of calcium in our GI tract is vitamin D. So either one of these, the lack of either one of these, either ingesting calcium or getting enough vitamin D, can cause calcium deficiency or lack of proper mineralization. So I'm just going to write lack of calcium ingestion and or lack of vitamin D. Now, we do make vitamin D when our skin is exposed to UV light. So we have the ability to make vitamin D, but if we don't get enough sun exposure, that causes a lack of vitamin D. We can also ingest vitamin D. So there's two ways we can get vitamin D into our system, either through sunlight or through ingesting it. Lack of either one of those doesn't allow calcium to be absorbed in our intestines. So it's more complicated than that, but that's the easy version. So that is what can cause osteomalacia and rickets in young people. It's usually dietary caused and or lack of sunshine. Now I'm going to talk a little bit more about osteoporosis. I do want you to know this term first. Osteopenia refers to the typical reduction in bone mass as we age. And this is due to as we age, osteoclast activity remains at relatively a consistent, I'm just going to write the same pace, but osteoblast activity decreases. So osteopenia, think of this as the normal sort of thinning of bones as we age, and it's because osteoclast activity keeps chugging right along, degrading bone tissue, and osteoblast activity decreases. So we're not making as much new bone as we're removing older bone. It's basically what this means. And this is hormonally regulated. And it's typically what we call sex hormones, but those are just steroids, androgens. So hormonally regulated, I'm going to write sex hormones in parentheses. We call them sex hormones just because it's estrogen and testosterone. So here's the deal. Steroid hormones, I'm going to put in parentheses, estrogens and testosterone. As we age, the production of these hormones in the body decreases. And these hormones tend to not only help increase osteoblast activity, but they also keep osteoclast activity at bay. So when we lack these hormones, osteoblast activity decreases. So lack of these hormones causes a decrease osteoblast activity and a slight increase, really it almost stays the same, osteoclast activity. That is why aging people, their bones decrease in mass. Women are at a particular risk. because after menopause, so I'm writing post-menopause, estrogen levels really decrease in the body. And so, more so than testosterone levels decrease in males, they both have a decrease in their steroid hormones, but in women, it's just more dramatic. And so they're at higher risk for thinning bones. And I talked about, and I'll expect you to know, the amounts of bone mass that are lost per decade in women versus men. It gets quite significant. It's like 8% per decade in women after their late 40s. It's 3% per decade in men throughout their life. So both are at risk, women much higher than men for the reasons that I just described. Now, there's other risk factors other than just aging and reduction of steroid hormone. And those are lack of exercise. Because as we learned in the previous sections, exercise / stress, tendons pulling on bones, invigorate osteoblast activity from Wolff's Law. A small physical body frame or size increases the likelihood of something like osteoporosis, lack of calcium in the diet. I'm just going to say lack of vitamin D. That means either from lack of sunlight, or we can supplement if we don't get a lot of sunlight. If we live in an area in northern hemisphere or deep southern hemisphere that the days are short, or we just live inside most of the time, our skin does not produce a whole lot of vitamin D. We can supplement that dietarily. So lack of vitamin D, either from lack of sun or diet, and smoking can also increase the chances of osteopenia and osteoporosis, because what smoking does is it also decreases estrogen levels. All of these factors contribute to osteoporosis. I want you to remember that osteoporosis is just sort of an extreme form of osteopenia. When you hear or read the word osteopenia, that happens in almost everybody. Osteoporosis does not happen in almost everybody. This is when osteoporosis is when osteopenia, which is this process, I'm just going to write the normal decrease in osteoblast activity. And remember, osteoclast activity just keeps chugging right along. When it gets so severe, osteoporosis is when bones get so thin and brittle, they can fracture, they can break. So bones get so thin and brittle, structural integrity of the bone is compromised. Okay. Now, there are some treatments for osteoporosis. Probably the most common one, calcium supplements. So we increase calcium in our diet. That will help for proper mineralization. So calcium supplements don't cure osteoporosis. They just help it from what calcium supplement really does is allows the body for proper mineralization. So if we don't have enough calcium, that's a huge risk factor for osteoporosis. There's no guarantee that if you eat enough calcium that you won't get osteopenia or osteoporosis, but this is certainly an easy way to help prevent it from occurring in the first place. There's also hormone therapy. So it makes sense if a reduction specifically in steroid hormones like estrogen is what causes osteopenia and osteoporosis to occur in the first place, why not just give more hormone? And in very, very extreme cases, hormone therapy is given. However, there's also risk with this involved. So it's not just hormone therapy is not handed out without deep consideration of the individual, because some hormone therapies have been linked directly to ovarian cancer, breast cancer, testicular cancer in men. So it's not without its side effects. Bisphosphonates, B-I-S-P-H-O, phosphonates, are also, I spelled that wrong, hold on, let me erase that. Bisphosphonates, there we go. These are all, this is also a supplement that can be given. It decreases osteoclast activity. So those bone cells that are degrading old bone tissue, dissolving old bone tissue, if we can slow those down, it affects their progress, then hopefully we can slow down osteoporosis. None of these are a cure. They're just treatments that help slow down osteoporosis. And then I'm just going to write prevention. The great thing about exercise, especially when we're young, is that helps prevent osteoporosis from occurring in the first place. It's most effective, though, when we are still growing. The theory is if we have thicker bones, exercise promotes bone growth. So if we have thicker, stronger bones before osteopenia onset, then hopefully we will not, that osteopenia will not lead to something like osteoporosis. So let me just, I'm just checking the, I just admitted another student. I just want to make sure that that student got in okay. So prevention, we can do things like exercise, proper calcium and vitamin D. Also helps prevent osteoporosis. Lack of alcohol and soda in the diet also helps prevent it, because alcohol and carbonated beverages, they call it, I just wrote soda, these contribute to leaching minerals from bone matrix. So these actually leach minerals. It's been proven that they leach minerals out of bone matrix. All right, so that does it on osteopenia and osteoporosis for now. I'm going to layer over this and just talk about Paget's disease really quickly, which is not super common. It's sort of the opposite, in a way, of osteopenia / porosis. This is an abnormal bone growth slash ossification. It's not like a abnormality in something like growth hormone in which somebody grows really abnormally large. It doesn't have to do with that. It's almost like pieces of bone grow uncontrollably on the bones themselves. So it's sort of random bone growth, spots of bone growth on our bones. And so I'm just going to write random ossification. That's supposed to say on. So it's not, it doesn't sound like it would be that terrible of a thing, but it's not compact bone that typically grows. It's usually spongy bone, sort of soft spongy bone that grows haphazardly in random areas. Usually affects people, older people. It's super rare for somebody to have Paget's disease under the age of 40 or 45. So it definitely affects the elderly. And it can be very, very painful. All right, that's just a quick description of Paget's disease. We say that this random ossification of spongy bone, we call that Pagetic bone. And that's the stuff that's sort of randomly grown on the bone that can be very painful. All right, for the last of this business, I'm gonna go over joints. So I'm gonna skip straight to chapter 8. I'm just gonna call up a new page here. Talk briefly about joints. I'm going to quiz you tomorrow. Included on the quiz is going to be sections, I think I said 8.1 through 8.4. So the first thing is this word arthro, or this prefix, that means joint. Okay, so that's just a quick definition. Whenever you see arthro, arthritic, arthroses in a name, just think of the word joint. We classify joint. I'm just writing the word classification. And this is where keeping these this organization in our heads can be somewhat of a challenge. So when I think of classification, I always first think of by function. I'm going to write type of movement, because this is the easy one. So there's 3 basic classifications by function. First one is called syn arthroses, or we use the adjective synarthrotic. That is just describing a joint that is completely immovable. Right? Then the second classification is amphi, A-M-P-H-I, arthroses. And these are joints that are partially movable. So I'm just going to put slightly movable. And finally, number 3, diarthroses are fully movable. We have all three of these all over the body. We usually think of these when we think of a joint because they're the easy ones and they're the most visible from the outside of the body. So those are the three classifications by function or the type of movement. Now, all of the structural classification joints will fall into one of these three categories. That gets more confusing. So I'm just going to layer over this page and go through the structural classifications, and then I'm going to relate them. All of those structural classifications will fall into one of these three classifications by movement, all right? Structure means just what are they made of? What type of tissue are they made of? Fibrous joints, just like the name says, are made of collagen fibers. The confusing part or the challenging part is that there's three different types of fibrous joints. So I'm just going to write A, B, and C. A suture, which you should know now from studying the skull in lab, doing your lab assignments, a suture is typically made up of short collagen fibers. I'm just going to write short fibers, parentheses. These are joints between actually cranial plates, mostly in the skull. Our skull is full of sutures, and these are totally immovable. That means they are synarthrotic joints from our first three classifications. Okay. So what I'm going to do is list these classifications by structure and then always try to get them classified by function at the end. The second type of fibrous joint is called a syndesmosis. Syndesmoses. And these are longer fibers. I'm trying to squish this in here. So syndesmoses, they're longer fibers. I'm going to give you an example of where bones are tightly knitted together. So like the tibia and fibula in the lower leg, where they connect to each other would be a syndesmosis joint. So I wrote tibia and fibula. And syndesmoses, these are slightly movable. And from our first classification of functional classifications of joints, these would be amphiarthrotic. And the third type of fibrous joint, C, is called a gomphosis. This is a peg in socket. It's just where our teeth insert into our maxilla and mandible. So I'm just writing peg in socket. I'm going to put in parentheses teeth. And these are also immovable, just like sutures. So gomphoses are also synarthrotic. All right, so that does the fibrous joints. Now I'm going to do the cartilage joints next. I'll leave this page if you need me to come back to it, don't worry. Just going to layer over the top. This is number 2, cartilaginous joints. So number 1, fibrous joints, just think fibrous connective tissue, collagen fibers. Cartilaginous joints, obviously these are cartilage or joints made of cartilage. The hyaline cartilage joints are actually the most common. These are made up of, I'll tell you, either hyaline cartilage or fibrocartilage. First one on the list, I'll write A, are called synchondroses. Chondro means cartilage, so that's a dead giveaway there. These are always hyaline cartilage. All right. These are, I'm going to give you an example, like a growth plate, epiphyseal plate. Is a very typical one. Also, costal cartilage. Costal means ribs. So it's the connection between the rib and the sternum is a synchondroses joint. And their mobility is that they are immovable. Put a star here. Immovable joints are synarthrotic. And good thing there's only 2 under the 2 subcategories under cartilaginous. The other ones are made of fibrocartilage, and they're called symphyses, or symphysis is singular. We know where these fibrocartilage joints are because when we studied fibrocartilage, we listed locations in the human body. So I'll give you examples. Intervertebral discs. It's supposed to be an R. These are symphyses as well as like the pubic symphysis. And the meniscus of the knee, by the way. So there's some examples. These are considered slightly movable or amphiarthrotic. And then the last type of joints that we have based on structural class, so I'm going to put a number 3 on the next page. So we've had fibrous, and we just studied cartilaginous, and then the third major type based on structural classification is called synovial, which I'm sure you heard of. Now this is a complicated joint, so it's made up of many different substructures, but there's usually, there's always a fluid-filled cavity. And the fluid is called synovial fluid. just so you know, the key ingredient in that fluid, I'm going to draw, after I write a few things, I'm going to draw a picture of a synovial joint just so you get the anatomy of it. But this synovial fluid contains, I mentioned this, I believe, the first week. It's called hyaluronic acid. And this helps reduce friction. So I'm going to put lubricating. And it's secreted by the membranes that make up that joint. So synovial joints, just think fluid-filled cavity, secrete synovial fluid, which contains hyaluronic acid that reduces friction and helps with lubrication. These, of course, are fully movable joints. So they're diarthrotic. In functional classification. And I'm going to quickly, I'm going to call up the next page and to show you the anatomy of a synovial joint really quickly so you get an idea. I'll expect you to know this anatomy for the quiz. Yes, I'll ask you some questions about it. Let's just say here's a bone and here's another bone. They need to articulate with each other at a joint. There is articular cartilage on the surface of each of these bones. I'm exaggerating the space. There's not this much space between two bones at a joint. It's just so we can fit it all in. And there's articular cartilage on the surface of this bone. These fully movable joints, as I'm drawing, I'm going to say, are found at joints that you know, like the pectoral girdle, the shoulder, the knee, the hip, anywhere where we get plenty of movement. Those are the joints that you and I think of when we think of the word joint. So let's just label this, obviously, bone, bone. This blue stuff is articular cartilage, which, to remind you, is hyaline cartilage tissue. Now, in a synovial joint, there is something called a synovial membrane that I'm going to draw next that encapsulates this area. And it's a serous membrane that's double walled thick. So it's 2 layers. They're sort of fibrous membranes. And we call this the synovial membrane because those are the actual tissues that secrete synovial fluid. I'm just going to put secretes. It secretes that fluid into that space. So the synovial fluid is actually found in this space here. And remember that fluid contains hyaluronic acid. Now there's a fibrous capsule on the outside of the synovial membrane. So I'm just going to use a different color. So this fibrous capsule sort of encapsulates the whole thing. Tough, fibrous connective tissue. So I just wrote outside because it encapsulates the entire joint. On the outside of that, there are ligaments. So I'll use green that help hold the two bones together. And finally, the last thing that I'm going to draw is just that there's nerves and vessels that penetrate all the way into the synovial membrane. So let's just draw some blood vessels, bringing nutrition to those actively secreting membranes. I'll just label this vessels and nerves. So that's the basic of what a synovial joint looks like. And just remember that the membranes are closest to the encapsulated fluid, and they are the source of the fluid. They secrete that hyaluronic acid that acts as a lubricating fluid in, sorry, I meant to use black. They secrete a lubricating fluid in here. Now, you've heard of people getting fluid injected into their knees if they're arthritic. That's only a temporary Band-Aid, by the way. It usually doesn't last very long. Oftentimes, these membranes, as we age, decrease in their ability to secrete that fluid, and then this hyaline cartilage starts rubbing on cartilage and wears away. And finally, an arthritic joint, osteoarthritis, is when bone actually grinds on bone because of the complete wearing away of that articular cartilage. That's what creates inflammation and pain, is when bone finally starts to grind on bone. Okay, so let's just wrap up with movements of, I'm just going to do, by the way, I'm looking through my book as I'm talking, and table 8.2 is 2 pages in your textbook. It's sort of mind-boggling and a little dizzying. I'm not going to expect you, obviously, to memorize that table. That would be crazy. However, I will ask you a couple questions on tomorrow's quiz, 2 or 3 questions about different joints, locations, and their types. So, like I said, I don't expect you to memorize it, but when you're taking your quiz, I would familiarize yourself with that table, with those tables, so that you can do a quick reference when you're taking your quiz. What I'd like to finish up with are movements at synovial joints. So I'm going to layer over this page, and I'm going to describe these movements to you, and I will expect you to be able to recall these movements very quickly on the quiz. Remember, synovial joints are, this name means fluid-filled, and they are classified as diarthrotic joints, which are fully movable. The first types of movements are gliding movements. That just means that one surface of a bone is gliding over another, just like the name states. Think about movements in the wrist and ankle. So these would be at the carpal bones and tarsal bones, are particularly good at gliding. Now we're going to go into angular movements, and I'll give you an easy way, hopefully an easier way to remember these. Flexion occurs at a hinge joint. Hinge joints, the most common ones are the elbows and the knees. There are others in the body, like in the cervical vertebrae of the neck. But I prefer to think of these as when you make a muscle in your biceps brachii, That's a hinge joint right at your elbow. And the definition of flexion is this: it's decreasing the angle at a joint. And it's a hinge joint typically. So if your arm is extended outward, there's your elbow, here's your forearm, and you make a fist. And then you make a muscle, or you try to flex, contract your biceps brachii, or you just made a big muscle. What you've done is you've decreased this angle. So here's the joint, the elbow. We've got 180 degrees when we extend our arms straight. When we flex and make a muscle, we've decreased this angle to 90 degrees. That's why we say it decreases the angle at a joint. So that's flexion. The opposite movement is extension. So these opposing movements, flexion and extension, occur at the same joints. So also at hinge joints, same places, and this is just increasing the angle at a hinge joint. So it's going in the opposite direction from 45 degrees, from being flexed to extending to 180 degrees. There is something called hyperextension. You've heard of that. That's going past what the body was normally designed to do. Hyperextending something is would be going past this 180 degrees. It usually causes some, not always, but usually causes some sort of damage to ligaments in the joint. So we've done, let's see, gliding, flexion, extension. Now I'm just going to do abduction. Abduction just means moving away from. So it's moving something, usually a limb, but moving away from the midline of the body. So if you stand straight, if we had a person standing straight facing us, and their arms are down at their sides, and they extend their arms upward and outward, that would be abduction. They're moving their arms away from the midline of the body. If the opposite movement is adduction, ADD, that's moving toward the midline of the body. So if they relax their arms down at their sides again, they are adducting their arms. Now it's not just moving our arms. We can do the same with our legs. If you're standing, if I'm standing facing you straight in front of you, and I put all my weight on one foot, and then I raise one of my legs out to the side laterally, that would be abducting my leg. And then bringing it back toward the midline of the body is adducting or adduction. The last example I'm going to give you is, this is hard to picture, but doing push-ups is also an abduction and adduction movement. So if I'm going to do a push-up, if I'm down on the ground and this is my head, there's my nose, I'm looking down at the ground, here's my back, my shoulders, and I splay my hands out like this. You can see I've already abducted my arms, meaning my humerus bone right in here. Those are away from the midline of the body now. if I do a push-up and push myself up, like this, I've moved my arms toward the midline of the body. So doing a push-up is actually adducting, making my arms go from away from the midline toward the midline of the body. So push-up is actually a movement of adduction. Let's do the last bit and we'll be done for the day. Circumduction. That just means scribing a cone in space. I'm going to do circumduction and rotation at the same time. Rotation is actually twisting on an axis or turning on one axis. So I'm going to do circumduction and rotation. I'm going to get rid of these boards and do these for you in person. So I'm going to hold my arm out. Don't know if you can see it, I'll get further away from the camera. Rotation is doing this with our arms. It's just keeping our arms straight but turning on an axis. This is rotation. Likewise, at the cervical vertebrae, if I stand straight and we do this, we just turn our heads, that's also rotating on an axis like this. So this is rotation, turning on an axis. Circumduction is a bit more complicated. We can do circumduction at ball and socket joints, like the pectoral girdle, the shoulder, as well as down at the hips. It's easier to do up here. So remember, this is rotation, turning on an axis, meaning this is one axis. Circumduction is doing this. It's described as scribing a cone in space, this being the point of the cone at the shoulder and the base of the cone or the wide portion of the cone out here at my fist. So there are two different movements. We can only circumduct at a ball and socket joint. Rotation can occur at different places of the body. Here, this is also rotating if I turn my whole trunk. But circumduction, remember, occurs only at ball and socket joints. Supination and pronation is this. Supination is turning the palms upward. Pronation is turning them downward. Dorsiflexion and plantar flexion just means plantar flexion is when we stand on our toes or point our toes. So that dorsiflexion is the opposite. If you take your toes and you turn them upward like this, that's dorsiflexion. Inversion and eversion means inversion is turning something toward the midline of the body. I'm not going to show you my feet, but if my feet were on the ground like this, if I turn the soles of my feet inward toward the midline of the body, that's inversion. Eversion would be if I turn the soles of my feet outward like this. That's eversion. Protraction and retraction, those are a little bit easier to show you. That's jutting my jaw forward and pulling it back. We can do that at this. This is a hinge joint up here at the mandible. So protraction is jutting forward. This with your jaw, retraction is pulling it back. Finally, elevation and depression means lifting a body part upward. So you can see my shoulders. If I elevate my scapula, my shoulder blade, that causes me to do this. Depressing is moving them downward. So anytime we move something upward or elevating, depressing is downward. Opposition is done at a saddle joint of our metacarpal 1. We have opposable thumbs. Humans do. Fully opposable thumbs. Opposition is taking your thumb and pulling it across the palm of your hand to touch your pinky. So I am going to go over some of those. I'm going to require you to know some of those movements on tomorrow's quiz. But we got through all of it. It's only 5 after 10. If you have any questions for me, just unmute yourself. I'm going to turn off my recording now. Maybe it stopped recording. There we go.